Dear Chairman, dear ladies and gentlemen, it's a real honor and a pleasure to be here today. And in my talk, I may follow up with what Thomas already told you. Let me briefly spend a few minutes on unmet medical needs in Wilson disease. We already are in the discussion about paradoxical worsening despite therapy. This for sure is one of the most prominent unmet needs. And later on, I would love to discuss with you a bit more on the data on trientine and tetrathiomolybdate. When looking at Wilson disease, and we've been discussing this the whole morning, one thing I wanted to point out is that an alternative explanation for worsening or insufficient control of the disease might not be constitutional factors like when the diagnosis made, how severe and the neurologic findings in MRI, etc. But likewise, maybe let me point to the circulating free copper pool that could be assessed by the surrogate biomarker non-ceruloplasmin-bound copper, or can be measured directly, as we maybe will hear in one of the later talks. That the concept of the toxic copper pool might likewise be an explanation why we see in some patients a treatment success and in other patients not. Thomas already has introduced you to the history of drug development in Wilson disease, and we had a good start, but then for a long time nothing happens. And this is what we have in clinical data. Was already outlined as primarily retrospective data, center series, large cohorts, nevertheless, but very, very few prospective data. And following that concept of the copper pool, we do not really know how the toxic copper pool and the non-toxic copper pool really behave during course of treatment. We know that there is a significant diagnostic value when addressing measurements for this free mobile toxic copper pool, but what happens during treatment is not really elucidated yet. We have center experience here, our own data showing that over time the toxic free copper pool under treatment should become normal. I'm pointing this out because there has been some seminal landmark work from the Brewer group who described in 3 of their patients that an increase in the toxic copper pool preceded the neurologic deterioration, so that when you have an insufficient control and then shift towards free copper, there is an increased risk of neurological deterioration. From clinical experience, these data have not really been prospectively followed or validated, and by far the best data we have in neurologic worsening come from the group from Anna here from Warsaw, where we have really long-term following. And what I want you to take home from this slide is that when you have patients without neurologic symptoms, these patients are not at risk for developing neurologic deterioration. However, despite treatment fails in some of these patients, and especially in such unfortunate cases like Thomas presented you in the talk before. Nevertheless, the role for NCP copper, non-ceruloplasmin-bound copper, still remains unelucidated because it was not available in the published larger series. Whether such worsening or deterioration in Wilson disease really relates to the copper pool or whether it relates to other things already mentioned has been compliance is unclear. Maybe this goes hand in hand, and this really, in my eyes, a landmark paper shows you that compliance is key in Wilson's disease, and if you can establish relationship with your patient, guide him through the therapy, this is the best thing you can do. And this is maybe likewise something I've learned from Anna and her group, that you have to be really passionate and you have to be dedicated to your patient. And this is why I'm pretty sure the results concerning treatment from the Warsaw group, when you look at what is published, are far better than what general should be expected from large centers. And I think it's passion and dedication, and thank you for that, for teaching us that, Anna. So let me briefly summarize high unmet medical needs in Wilson disease. I think we need effective control, we need a good drug, we need a good physician, we clearly need a strategy to reduce risk for neurological worsening. The topic of adverse events was already touched ground with in the previous talk, and maybe we discussed combination therapy already, we need just a very simple dosage regimen to improve compliance and adherence. So what might be other options despite the penicillamine and zinc? One might be trientine. Trientine is very old, but very recently got an approval for a trientine generic. And our center experience from Austrian and German tertiary care centers comparing 300 dipenicillamine treatment with roughly 140 trientine treatments showed finally that there was, regarding efficacy, no real difference. But what we found is a better safety profile from trientine and more treatments stopped due to adverse events or suspected adverse events under dipenicillamine. Outcome, likewise, Mike Schilsky wrote in an editorial, 85% good. However, we still have nothing new regarding mode of action. Thomas touched briefly the topic that tetrothiamolybdate may have a different mode of action, and this comes from seminal work from Brewer with the ammonium tetrothiamolybdate salt, and now the bischoline tetrothiamolybdate is being developed for Wilson's disease. What is special about this compound per se? It's a very strong copper binder. It binds very specific with a high affinity. The affinity of the binding is so high that copper is even released from intracellular copper stores. It augments copper excretion into bile. And let me come back to the concept of the toxic circulating copper pool. It has the ability to form a very stable complex between copper in the circulation together with albumin and the bischoline tetrothiamolybdate. And this complex, the so-called tripartite complex, is very non-reactive, and copper is just stored away. So together with some centers in the US and Europe, Anna and myself had the pleasure to be involved in a clinical study on tetrothiamolybdate. This was an open-label phase 2 study where we looked at adults with Wilson disease that might even have been pre-treated with other drugs like dipenicillamine or zinc or trientine for up to 2 years. These patients were then put on bischoline tetrothiamolybdate and were followed closely. And we looked at the free copper levels, we looked at the neurologic outcome, of course, a bit on the liver, and especially for safety and tolerability. And 28 patients were treated so far. Of these, only 9 had no previous treatment. The others have already all been pre-treated. You can approximately half of the patients had a cirrhosis, but none of these patients was really what we would call a liver patient. So all these patients nearly all had neurological symptoms, what is reflected by the scores in the Unified Wilson Disease Rating Scale. When we looked at the outcome of copper control in that trial, this is over time from initiation of treatment with WTX-101, the bischoline tetrothiamolybdate, we saw a rapid and consistent reduction in free copper levels. And going hand in hand with this, we observed improvements in neurological disability. This is the patient-reported part of the Unified Wilson Disease Rating Scale, showing improvement over time. And the same hold true for the clinical examination in in neurological status. So overall, this was an excellent response in treatment-naive patients or patients that had been pre-treated with other compounds before. Hepatic laboratory parameters, maybe to cut a long story short, remained very, very stable, as here shown for the MELD score, and when looking at adverse events in general. Overall, the compound was well tolerated during that trial. One of the most frequent reported adverse events were elevations of the transaminase levels, but all these elevations were transient and responded very well to dose modification or dose reduction. Other serious adverse events included psychiatric disorder, affective disorder, and unfortunately, some of these patients were, from the psychiatric underlying disease, not fit enough to follow the protocol any longer and were discontinued. But the LFT elevations from the liver function side all resolved within dose adjustments. So let me briefly summarize with this very last slide the mechanism of what is special about this alternative treatment. I think we have a compound that really enhances biliary excretion. This is more prominent than compared to the other chelating agents. And what I consider the most advantage of existing chelation therapy is the formation of these very, very stable albumin-copper complexes in the blood, giving this a modulating aspect of the compound just to remove the toxic copper from the circulation and hopefully leading to improved outcomes in our patients. Thank you for your attention.